Welcome, and thank you for joining this week's webinar in the COVID-19 and Humanitarian Settings Knowledge and Experience Sharing webinar series. We will begin shortly. During this webinar, participant microphones have been muted. However, we do encourage you to make use of the chat box to communicate with the presenters and to ask questions. Access to today's recording will be available after the webinar at readyinitiative.org and on the Johns Hopkins Center for Communication Programs YouTube page. It is now my pleasure to introduce our moderator for today, Professor and Director of the Johns Hopkins Center for Humanitarian Health, Paul Spiegel.
Hello, good morning and evening and afternoon, everyone. It's a pleasure to be here. We're going to be having this is the third webinar now of a series, and the idea of this series is to have an expert who is been involved in developing guidance of some sort, and then have colleagues in the field actually respond to how they have been attempting to implement such guidance or adapt such guidance to their context, because obviously from a headquarters position, it's extremely difficult to be able to provide guidance that will be specific to all different contexts. So the plan is we'll have Michelle Geyer, who I'll introduce briefly, will speak for approximately 15-20 minutes, and then she will then hand off to two of her colleagues, Mohammed Fawad and Darren Hertz, who will then give their perspectives and different perspectives from both Jordan and from Thailand. And then after that, we'll be throughout collecting all of your questions and or comments. We have a colleague who will be trying to put them all together, and then he'll be texting them to me, and then I'll be asking the various questions to Michelle, Mohammed, and Darren. So without further ado, I'm going to introduce our wonderful colleagues from IRC. Michelle Geyer is a physician and a director of emergency health at the International Rescue Committee, where she oversees its global program on health, nutrition, and WASH in emergencies, as well as outbreak, preparedness, and response. Dr. Mohammed Fawad. Dr. Mohammed has over 15 years of experience of humanitarian health programming and implementation in various countries, and he is currently the health coordinator for IRC in Jordan. And then finally, Darren Hertz, and Darren has over 20 years of experience in global health and development, and he is currently the director for IRC in Thailand. So we're going to have a presentation now, and I'm going to hand it over to Michelle. And thank you both, Michelle, Mohammed, and Darren, for coming and presenting your views today. You're on mute, Michelle. You can't get it off. Is someone that's controlling? Ryan, are you able to?
Thank you.
Has that.
That's great. Thanks. I couldn't unmute. It was done by you. Okay, so thank you, everyone. And thank you, Paul, for the introduction. If Ryan, could you put on the slides to, great. So today I'm going to speak a little bit about prioritization and program adaptation in humanitarian settings. And then I'm going to hand over to my colleagues to just give some practical field examples, and that's where most of the discussion will happen. So if you move to the first slide, please, Ryan. I think when we talk about organizational level prioritization, we have to think of it in three ways. So I just want to talk about a couple of these things before we go into program adaptation. In any agency, and particularly all our implementing agencies that are online, we probably have three priorities. Priority one, we have to prioritize our staff. Our staff need knowledge and supplies to work safely, and our agency needs the right policies and safeguards to support our staff and mitigate the risk for staff. A second priority is really around our program business continuity and leverage. So we have to ensure the continuity of critical pre-existing programs and services by adapting them to be safe and recognizing the secondary impact of major outbreaks on populations, as we know from previous lessons, such as Ebola in West Africa. But we also know that we can leverage our existing programs to control this outbreak, to help reduce transmission, to provide care for populations. This is critical. We have pre-existing programs because life life-saving interventions, life-dignifying interventions need to be put into place in a lot of the populations that we're working for and with. And if we don't continue these existing programs, we will leave them with nothing. And we really need to make sure basic needs, existing essential services have to continue. But we can do that by making them safer. So this is where I'll talk about the most of the presentation about. And of course, priority 3, we can do additional outbreak response activities. So when we talk about program adaptation to our existing programs to make sure that we're providing essential services, we can, on top of that, add additional activities to actually support containment and mitigation efforts to reduce the impact of the outbreaks. Right. So if you go to the next slide, this happens across 3 levels. Obviously, each individual can do something, each office can do something, and then obviously our programs. So this is what I want to focus on. If we move to the next slide. Our program level response, why is this important? First of all, every single thing that we're doing in the field, all our programs, regardless of whether it's in health or nutrition or protection or economic recovery and livelihood, all our programs have inherent risks, right? Which may promote the transmission of COVID-19 during an outbreak that comes to a country. So given that, we must adapt our existing programming to reduce this risk. So program adaptation continues to improve. What we'll do, it will continue to contribute to improved safety for our staff and for clients. It would support business continuity of existing programs to the extent possible. And also, by limiting further transmission, it can support outbreak response. And as I mentioned, additional response activities can be added based on the pillars of outbreak response, whether it's surveillance and contact tracing at the initial phases of the outbreak reaching a country, infection prevention and control, case management, risk communication, community engagement, etc. Next. So just a couple of steps in terms of program adaptation that I think are important to go through. And this has been done with some of my colleagues at the IRC. We kind of at January put our heads together to sort of think, well, how are we going to do this? So first and foremost, in terms of prioritization of our programs, first, programs really need to list their activities and rate what their criticality is. You can use any kind of method, but essentially it's something that has to be done at your country level by your country programs and the different programs. We chose, for example, to rate our criticality of our programs from 1 to 4. Obviously, you can do more, but 1 being the most critical life-saving interventions and 4 being less so. I'll talk about that in a minute. The second important thing to do is then actually do a risk assessment of each of the activities. And that means doing by each programming type, what are the risks that COVID-19 poses to these programs, and vice versa. Can your program, as I mentioned before, transmit or increase the transmission of coronavirus during this time? So it's a risk assessment of each of your programs. And then once you've done that, the third part is the adaptation measures, contingencies. So what are the things that you need to do to ensure business continuity? You may need to have accompanying thresholds for program suspension. You also need a clear list of resources that you might need to adapt your programs, etc. So I want to go through this in a bit more detail now. Next. So in terms of program prioritization, this is just an example of how we looked at it. So 1, we said the most critical activities, interventions are life-saving interventions. So this might be clinical care for emergency conditions, emergency water and sanitation hygiene, emergency food distributions, or cash. Number 2, we would say are probably life-sustaining interventions and those with a potential impact on COVID-19. So this could be primary health care, vaccination, maternal child health. Other things that have an impact on COVID-19 would be any community engagement activities that you're currently doing that could promote prevention. For example, if you have protection programming, you could leverage that to promote prevention of coronavirus, the social distancing, hand hygiene measures, etc. If you've got environmental health programs and hygiene promoters, again, the same. So this is one way of trying to sort of prioritize your programs. And then 3 and 4, we kind of classified as life dignifying and life enhancing, to I guess basically allow our programs to discuss what would be life-saving, sustaining, and then what are some of the life dignifying interventions and enhancing interventions that we would put into a category. Now, what do we do with this after we've done this prioritization? Next slide. So essentially what we decided to do was to say, okay, all 1 and 2 activities, we will continue, and we will do them with identified program adaptation measures when there is confirmed local transmission of COVID in the areas of our operation. We will only consider temporary suspension if our risk mitigation measures cannot be implemented, right? But we will do our very best to try and ensure that programs continue. And what we decided is that given what would happen during local transmission, examples from other countries, we have said that we would suspend our 3 and 4 activities. Next slide. So in terms of your risk assessment, one of the things that is probably the most useful is to look at your programs by modality. So it's not saying, okay, education does this and therefore you need to stop activities, or your WASH is doing that and therefore you might need to continue that. No, it's really looking at the modality, and this is what the risk assessment is about. It's regardless of what sector, do you do household visits? And if you do household visits, B, what is that anticipated risk? Because household visits mean that you get close to people, you may then contract COVID or give the individuals COVID, and that would transmit. So it's really looking at the different modalities in which we program and how we deliver services. So they could be obviously mass meetings or gatherings. Obviously health facilities are a modality in which we deliver our services. There could be a variety of centers, for example, nutrition centers that are not attached to health facilities where we deliver services. Schools, there could be spaces of sorts, so child-friendly spaces, women's-friendly spaces, community rehabilitation spaces, mental health psychosocial support spaces, etc. All of these have inherent risk because people gather. Distributions, again, and finally, things like community construction rehabilitation. Now, this is just a short list. There may be other modalities in which you are programming. And so it's really important to consider what is the way in which you deliver a service and what is that anticipated risk for each of those modalities. And once you've done that, next slide, comes the harder part, is really thinking through the mitigation measures. What you would do, so mitigation measures are really what you would do to change that program or that intervention to make it safe for yourself as in a staff member and to make it safe for the clients. Then you have to think through the resources that you might need to do that and your implementation plan. How would you go about implementing that? When would you think about stopping or not stopping? When you think about restarting? Also thinking about lockdowns. If there's absolutely no movement allowed, how would you implement something like that versus if there are partial movements allowed? So this is essentially a kind of a run through of the steps you might take in terms of looking at your program adaptation. So a couple of, next slide, please. So I just want to give you a nutrition example. So for example, an outpatient management of SAM and or MAM, our nutrition team, tried to put together some global guidance for our teams on the ground. And they said, okay, wherever possible, try to deliver all your treatment for uncomplicated wasting by community healthcare workers using a limited or no-touch simplified treatment approach. And they have suggested our program modifications can include simplifying admission criteria, expanding our admission criteria, simplifying the dosage, reducing frequency of follow-up visits, carers and caregivers to practice social distancing, for example, and so on. So these are some of the things that we could recommend. How we can actually do them in the field is a different matter, and that's where my colleagues will come in to talk. The next slide, before I finish. Another example, for a health facility adaptation, the sorts of things that we would do, again, sounds very standard, but when you go through them and you think about all the things you have to change, that's a lot. So readapting, I mean, many facilities in which we work in countries don't really have very good triage and screening areas for a respiratory illness. So really trying to ensure that there's a good triage, screening and isolation area for potential suspects of COVID. Ensuring and reinforcing stranded IPC precautions, but also transmission-based precautions. Providing PPE, an issue we'll come to in a minute. Strict staff sickness policies. Home-based treatment protocols, because not everyone can be treated at the facilities. Cancelling routine non-urgent services. Preparing for disruptions in patient access. What if there are too many people in the service and or people can't get to the service and they need their drugs, for example. Limiting visitors and movements, writing down patient transfer protocols in this new environment. What about surge capacity? Not just beds, what about your staff? And things like PPE conservation strategy. What if we are running out? What might you do? So that's a lot of things just in a health facility. The next slide, the main point being, next slide, please. The main point being that we have to continue to ensure basic needs, but what you can already see is that program adaptation takes time and resources. And of course, it's not only the health sector. All sectors can be leveraged to reduce transmission and provide community isolation or care for ill patients during this time. It's not going to be perfect by any means. It's not going to be static. It's really going to be context specific with its own local challenges and needing to really look for local solutions which evolve over time. And so what I'd like to do now, next slide, is to hand over to first my colleague Mohammed, who will speak from Jordan, and then straight after him, Darren will speak from Thailand, just to give you some practical examples and challenges that we faced on trying to implement some of this program adaptation guidance. Over to you, Mohammed. And next slide.
Yeah, thank you, Michelle. Hi everyone. I will just be presenting for Jordan our health program adaptations, which we have done so far in order to continue this essential delivery of health services. So what I'm going to present is the exact, or not exact, but like the translation of what Michelle has presented, how we are translating those guidelines and activities on ground. So I will start from the first slide, which is mainly focusing on the essential preconditions to have a continuity of service delivery through a remote model, which we have developed in Jordan. There are a few definitely essential preconditions in order to do so, because in normal situation, the physical delivery is going on in the primary healthcare clinics. And because of the movement restriction, which we have seen in many countries, to operate or to continue this service delivery by the primary healthcare system is not possible because of the severe movement restrictions. So that led us to come up and develop a remote model for service delivery in this situation. So what I'm going to present is mainly focused on our urban clinics, and we definitely have an element of the remote delivery in the camps as well, because in Jordan, the camp situation is that the movement is possible. They have allowed a specific number of essential staff to access the clinics and provide the services, but in the urban areas, it is complete lockdown, and the clinics cannot operate the way they operate in the regular situation. So the essential preconditions which we faced are the health information system is definitely a very important element of the health service delivery. So a comprehensive health information system is definitely essential, which is flexible to be adapted to the remote delivery model. The second, in our remote delivery model, which we have observed, is the connectivity. You need to have a very good level of connectivity, and the internet and the phone coverage should be available in order to do the remote delivery. System adaptations, definitely we adapted our system, to work in this situation by remote model. which definitely I'm going to present after a couple of slides. So that is definitely an essential, and those systems and the standard operating procedures should be flexible enough to be adapted to a changing situation. And definitely the very, very important element of the service delivery is the delivery of medications to the patient. So we will go when we see the model in details, all those elements. Paul, next slide, please. Yeah, so this is just like a very brief shape of our remote delivery model. Our principle definitely to have the service delivery always patient-centered and in a safe way, as per our guidelines. We definitely did service adaptations and systems adaptations as well, with a lot of customization of the existing system in order to deliver in such situation. And definitely the third element is very important, like our all efforts for humanitarian health assistance in Jordan is very well coordinated with the Ministry of Health Jordan and UNHCR, who is taking care of the refugee population in Jordan. So the model basically delivers two types of broad services, which is non-communicable disease and the essential reproductive health. So these are the two elements which we have so far included in our delivery model, and definitely we are also thinking of inclusion of more services, but that is definitely going to take time, because again the service modification adaptations will be required to do so. Next slide, Paul. Yeah, so this is just, I'm not going to describe that because this is just like to give you an idea how our remote service delivery in the urban clinics work. There are flowcharts developed because it's a complex process, and we have based that model on 5 scenarios. Those scenarios are developed because of the ground situation of complete movement restriction or some flexibility of movement restrictions. So I will just not describe these because it will take a lot of time, but just to give you an idea that the model depends on these 5 scenarios for delivery. Whatever scenario comes into play will be applied on service delivery, and the service delivery can be a combination of 2 scenarios or 3 scenarios. Next slide, please. Yeah, so this is like this is the slide on which I will spend some time to explain that, because that is those are the steps which are like essential to deliver through the remote delivery. We start from step number 1, which is retrieving the data from our health information system. So we have a health information system which contains the patient's information, the past medical history, and the medicine prescribed. So it has all those essential information available inside, and definitely it contains the patient's address and the phone number. So all those essentials about our patients are there in the health information system. So just to make it clear that I'm focusing here on the non-communicable disease cohort, which we have been serving before the lockdown, and some essential reproductive health services. So when the data from step 1 is retrieved, then we prepare the lists of the patients on daily basis. The number depends between 25, 30, and 35. So those lists are prepared by our data health data unit, and in step number 3, they are shared with the clinicians in the clinics, which starts from a pre-consultation by a nurse, and it takes into account the past medical history, which is available definitely by the retrieval of the data by the health data unit with the nurse. And then she calls the patient and conducts the pre-consultation with the patient, again on based on the condition diagnosed or previously for the patient. And it also includes some screening questions about the present condition of the patient, and some lifestyle modification advices and the status, how is it going. So that is a pre-consultation done by the nurse, and we move to the next step, which is the consultation by the medical doctor. it is just like a virtual clinic, which we have the flow of the patient in the regular situations. So this is just like an adaptation to the virtual online consultations in the process. So the doctors conduct the consultation with the patient, and then based on the condition of the patient, there are multiple scenarios which we have seen in the last slide. If the patient is stable, definitely we have the criteria of stability of the patients as well, which is available in our model. So based on that, if the patient is stable and there are no aggravating symptoms of the existing condition, the prescription is written. And then the prescription goes, now this is the green slide, which I definitely want to focus more, because that is very, very important step in the process. The prescription is shared with the contracted pharmacies, which we have been contracting before the situation since our humanitarian response. So we have contacted pharmacies who have our essential drug list available with specifications and quality standards maintained. We have a whole process for that. So they, in the normal situation, when the patient physically visit the clinic after the prescription stage, which is stage number 5, the patient goes to the pharmacy physically and gets the medicine, and there is a process for that. But in this situation, as the patients cannot leave their houses, our contracted pharmacies have got the permits from the authorities, and they can move. So one of the options is, in the scenarios that when the prescription will be shared with the pharmacy will deliver the medications to the household of the patient. So this is one of the options which which is now implemented in the given situation. But there are multiple other options as well. For example, if there is flexibility for the movement, the patient can go and get the medicine from the pharmacy, or if we are allowed as the IRC to operate in that area, our drivers can deliver the medications. And then on the right side of the green oval, we have an option in the camps, because in the camp, the movement restrictions are not like the urban areas. There is a greater flexibility there. So in that situation, we have the volunteers, and after completing all those steps, the volunteer goes and deliver the medicine at the household of the patient, which we will see a video later on to know the process, how it works. So after that, when the medicines are delivered to the patient at the household, we confirm and we receive the feedback about the process of the whole process, not only the delivery of medicine, but the whole process, how that whole process went. Are they happy, satisfied with that, or do they have any suggestions to be taken into account for the next appointment? That is a process which I have tried to describe in circle, and it is a continuous process which is implemented. And then the last step is we appoint, we set the next appointment for the patient. So that is the whole process. I try to describe it. It is really complex. If you go to the flow charts for individual scenarios, like very complicated, not to be describable here. I hope it was a brief presentation and straightforward about the process. Yes, Paul, can we move to the next slide? Yeah, this is now in process. We divide our health program in Jordan into main components. One is the community health component, and then the clinical services delivery component. So we resumed the services for the non-communicable diseases through remote delivery model, and some reproductive health as well, including family planning, added to that recently. But the community health from the project criticality point of view was not that essential as compared to the essentiality of the clinical services. As we all know, I mean, there is no need to describe how essential the NCD services are to be continued. So now we are working on a community health model remote, and this is just like the first version which we have created. And the main purpose of that virtual community health program delivery will be to keep the patients connected with the system and with the services as well. And we definitely will utilize some screening at the community level to identify the high-risk cases, not only for COVID, but for the general communicable, non-communicable diseases. And we connect them with the services either by the non-governmental organizations or provided by the state-run facilities. So that is a model. I will not go into the a lot of details here, but this is what like an essential component of the health programming, the community health, which we are not ignoring, and we are anticipating that we will be resuming our community health to the remote delivery very, very soon. Thanks. Paul, we can move to the next slide. Thanks. So, as definitely, I mean, remote delivery is the option. It's life-saving, definitely, without any doubt, but it has limitations. The limitations are that, for example, what we have faced so far, that we can serve only the NCD cohort, which we had pre-selected because we have detailed medical histories of those patients and we have been treating those patients at our clinics. So we have all the medical records. But for a new non-communicable disease patient, it will be very, very challenging, I mean, to deliver through this model. So this is one which we have observed. For the reproductive health, we can do antenatal care, we can do postnatal virtually, and if we identify any high-risk cases during the antenatal care checkup, we can connect them with the services. But again, some limitations are there. For example, for the family planning methods, we can only deliver those family planning methods by the remote delivery model, which are doable, like oral or condoms. But again, I mean, if we go to the full range of FP services, that will be very hard to do. Communicable diseases is another challenge which we have faced. Which will need, in our opinion, a high level of technology involvement. Technologies I mentioned in the beginning, in the first slide, that health information system is the absolute essential to deliver this model. So this, again, connected with that, we can definitely do communicable disease with some advancement and further adaptation of our services by video calling. So it is doable, but we are looking into it for the future. Which is, in our opinion, should be doable with some additional adaptation. Next slide, Paul. Yeah, I mean, these are only a few pictures.
Mohammed, if you can briefly, we need to move on just because of time. So please just go.
Yeah, that will be very brief, Paul. So these are a few pictures. We can move forward, Paul, with those pictures, just to give you an idea how the staff is engaged in online consultations. Next. That is the pharmacist preparing the medications for the patient, and then our senior health officer is receiving feedback and confirmation. We can now move to the video, Paul. I'm sorry, I've taken a lot of time. This video is just giving you an idea how the remote delivery takes place, the medication by the IRC volunteer to the household of a patient. This is after completing all that process, which I described. Now this is the last stage. Thanks.
Sorry, one moment while I load the video here.
While Ryan is loading it, Mohammed, can you just talk about Zatri camp, how many people, etc.?
Yeah, I mean, Paul, that is definitely very, very important. I mean, we have 2 refugee camps in Jordan, which host 20% of the total refugee population in Jordan. So health services delivery has been continued in the camps with some modification and adaptation. I didn't go into those details. We all know them, for IPC and for triaging and limiting the number of staff who are entering the camps. So otherwise, the camps are locked down because no one can leave and enter the camps. So the only people who are now accessing the camps are the staff of different organizations, mainly in the health and other sectors. So this is what is happening in the camps. And so far, we have been lucky that no cases have been reported from the camp. There was a random screening done a few days ago, and that was negative. So that's shortly about the Zatri refugee camp.
Please play, Ryan. Do you want to go over to Darren?
Yes, I'm done, Paul. Thank you very much.
Okay, thank you very much, Mohammed. Darren, over to you. Ryan, you may need to unmute Darren. I don't know if he's able to.
Hi, Darren, are you with us?
I'm with you.
Great.
Excellent. So hello, everybody. My name is Darren Hertz, Country Director for the IRC Thailand Country Program. We provide a range of healthcare services in 7 of 9 camps along the Myanmar border, as well as other protection and GBV prevention and some livelihood programming as well. This is a picture of one of the larger camps, Mela. Looks a little idyllic, but quite congested and a real concern right now for us on the border with COVID transmission starting to show in that particular province. Next slide. Great. So currently there are 9 camps. We are in 7 of these as healthcare providers, 75,000 refugees over 7 camps, 11 doctors, 10 field hospitals, 130 IRC trained medics. These are not accredited clinical staff. These are refugees that we train over a period of a year and gather experience working in the field hospitals within the camps. And hard to do a presentation without noting PPE. So just to note, we are currently at 1 month supply of surgical masks. We have basically a 3 kind of scenario planning and response approach. The first is largely based on the assumption that once identifying a suspect case, we can refer them to government district hospitals for testing and for treatment. Our scenario B of the way that we're approaching this outbreak response is basically that government hospitals begin to realize they're running out of capacity and they start to refer back mildly symptomatic cases for us to manage. And then the third scenario, the worst case, is where referral hospitals no longer have the ability to take on patients, in which case we then have to, in addition to doing surveillance, IPC, and continuity of critical services, we would also need to start on full case management. Next. So I just wanted to, I didn't want to go into a whole lot of detail. This is an interesting context. The Thai government has really launched a massive response since early January. It was one of the first countries to test and confirm an imported case from Wuhan. The government has been, I think, really pretty impressive in its surveillance and response capacity, as well as community IPC, public IPC, and overall, I think a population that has really kind of complied to a lot of the measures. So at this point, overall within the countries, we've seen back in late March what looked to be a rocketing of numbers, but then slowly that seemed to have been contained. And over the past 7 days, we're now averaging a daily rate in Thailand of about 39 cases. So it's been, by and large, a very strong effort by the Thai government. We as an NGO provide healthcare services to refugees who are not necessarily considered to have rights and opportunities to use the Thai public health system. To date, our engagement typically with the Thai health system has been referring patients to them and then paying for those referrals. Our relationships are excellent at the levels that we work, but in this type of situation where the government is the larger response actor, we have found ourselves in a very interesting number of positions where we feel like we're constantly trying to not fall through the cracks. I think just a couple of notes. I think this is probably relevant to a lot of different actors working with refugees in host countries. We have seen that the ministry that we work under is not necessarily the Ministry of Public Health, nor is it has it always been the ministry that is leading and making decisions on the response. So continuously, as we engaged in preparing ourselves, there was a constant process of trying to work to bring ministries together to be able to talk about the kind of issues that we were facing, the needs that we had, and how we could best collaborate with them. Another kind of crack, so to speak, that we were consistently trying to bridge is that between the central kind of level of government where we do have stronger kind of representation out to the provincial level where more recently all of the decision making has been devolved to. And so a lot of this again has involved us consistently spending a lot of time advocating, trying to bring the right people together to give us the kind of collaboration and support and ensure referrals, alignment with government surveillance and IPC protocols, et cetera, et cetera. Just go on to the next slide. This is a quick note. That earlier slide was one of the isolation units that we are preparing in our 10 facilities. This picture is at the entry to the camp, where we've spent time with the officials from the Thai government that overall are responsible for governance and security of the camps, in preparing them to be able to do a minimal amount of screening and setting up hand washing at all entries for people coming in and out. I note here obstacles of a larger pandemic response. I've already heard that a little bit from my colleague Mohammed. I think this has come in a number of the chat questions. Not having a place at the table in the larger government response coordination mechanism has also meant that we can fall through the cracks when it comes to accessing our camps. So one of the issues that we've recently had is, as measures taken by the government shift from the typical surveillance containing transmission, etc., onto these larger responses of locking down, of large-scale quarantining, etc. Many of these have been applied to us, which has been a real investment of our time and effort into consistently trying to kind of unblock these, consistently making cases that we are the frontline healthcare workers for this population, and that we need access. Interestingly, other issues we've seen out of the larger kind of pandemic responses here in Thailand by the Thai government was a large number of migrant workers many of them who were refugees at one time in the camps. And when some of these larger pandemic measures, lockdowns and curfews and closing up of businesses happened, we saw approximately 60 to 70,000 people fleeing from Bangkok and other big cities in Thailand to cross back over to the borders. What none of us expected to see was additionally a large number of refugees formerly living in the camps and others seeking shelter within the camps. I think a third kind of obstacle when it comes to this larger pandemic response is, I think, is trying to negotiate with what is often, I think, seen as the solution for the camps, which is really sealing them off. Right now, there's not really the full resources by the appropriate Thai government staff to be able to do that, and certainly this poses a lot of kind of protection risks for us as people do seek shelter from quite vulnerable situations outside the camps. So this is something we're constantly trying to work out and deal with on a daily basis.
Darren, just because of time, can I ask you to close up?
Sure,
and just make sure we have time.
Yeah.
Please go ahead and just maybe close as soon as you can.
Yep, next slide. Okay, and then this is really quick, just kind of an illustration of some of what we're seeing on that kind of some of those tensions between this notions of quarantining and locking down and sealing off the camps, versus the need to ensure protection of refugees who have been both out and trying to get back in to what they consider as shelter and safety. This was a quarantine set up by a camp committee outside the camp as what they figured to be the safest solution for returnees coming back in. This posed obviously a number of risks, and today we're happy to find another location within the camps where we could move these folks to. But this larger kind of response to be able to just quarantine large number of people because they're coming from other parts of the country has also led to a real challenge in allocating appropriately our own resources and finding the balance between supporting quarantining of safe and dignified quarantining of travelers and visitors coming in, with the need to really focus on preparation for an actual outbreak within the camps. So next. Just a couple of things we've noted. It's just been a couple of months, but really the importance of addressing the concerns of camp leaders first. Until their concerns are addressed, it's really hard to kind of engage and motivate people more widely. Second thing is a real strong protection pillar. This is something that became immediately part of our coordination mechanisms to help manage some of these more nuanced issues. We certainly found the more that we could give people something to do about the outbreak, this is the refugees, this is the camp leaders, this is the ministry camp commanders, the more that we could give them to actually do something about it, the better everything seems to work. Scenario planning has been a real important thing for us. We're already seeing now the possibility of not being able to refer patients in 4 of the camps, and madly scrambling to see how we might be able to find lab capacity for testing and the facilities in a somewhat primitive environment to be able to do treatment. And lastly, just the need to constantly be consolidating allies and strongly advocating for the population here. Just a couple of
Darren,
challenges.
if it's okay, we're going to have to stop so that we can get some questions in before we end.
Great, no problem.
Okay, thank you. Sorry about that. Okay, so thank you, everyone. What's interesting, we have a lot of questions, and some have been posted, some have not been posted. But what's clear is when you look at the two examples of Thailand and Jordan, you see very, very big differences, particularly in technology. And it's clear you see a difference between a much smaller country in Jordan, a middle-income country that has, I would say, perhaps more, at least in the areas where the refugees are, a more developed setting and a way to do things that you cannot do apparently in some of these areas in Thailand. So there are a bunch of quick questions I want to ask, and we'll likely only have one round, but we can see if there'll be another one. Firstly, to Michelle, there were a bunch of questions, and I'm sure you've read them, Michelle, but certainly some of them are in your prioritization. Yeah, we can all put on our videos, maybe Mohammed and Darren. So in your prioritization, how did you discuss NCDs? And then there's some questions about SRH, sexual reproductive health and maternal child health. How do you prioritize that? Another question is, how do you recommend to the countries to make the decisions in terms of prioritization when there are some extreme situations where there is no PPE? And then another big question about community health workers and their protection. Mohammed, a question for you specifically. What you're proposing is quite sophisticated and definitely resource intensive. What are your different scenarios when either you don't have those resources, or when we discussed ahead of time, you are relying on the government a lot in this response, and that may be doable for now, but if there is, and hopefully there will not be, severe community transmission in Jordan, what happens? And then finally, Darren, I'd like you to respond a little bit, if you wouldn't mind, to Mohammed and what they are doing there and what could be feasible or not feasible in your setting. And then just a very quick question on the government now, or at least in I won't say the area, the certain areas saying we no longer have tests for you. How do you respond to something like that as an NGO? And there are other NGOs as well working in these areas. So over to Michelle.
Hi, thanks. Very quickly, I mean, I think the point of doing the sort of prioritization, and I didn't specifically call out NCDs or MCH, etc., because there's a lot of services that are encompassed within that. And the first point I made was this is something that is done at the country level by the country programs, obviously, because the maternal child health services include emergency obstetrics, which would be a life-saving activity, whereas perhaps, let's say, vaccination, antenatal care is a life-sustaining activity. The point is, we've provided some sort of guidance to our countries, but 1 and 2 activities, life-saving, life-sustaining, are the ones that we're going to try and continue. So it doesn't matter; those 2 will go ahead. Someone asked questions around what's sort of life-dignifying, life-enhancing. It's really for our internal purposes. So I was trying to sort of give you an idea of why you might say, okay, well, look, life-dignifying services are something like safe spaces, and life-enhancing might be, education services, etc. But each time you have to think about, you could do all of them, but really right now, in this moment, as local transmission happens, how would you prioritize your minimal resources to be able to deliver the most important ones and sort of work backwards? So the second thing was around community health workers. I think, I think they're going to play a critical role because so much care is going to be happening, not just for coronavirus, for everything else is going to be happening in the community. So we do have to make sure that, we can train them to be safe. And that's why I said at the beginning, it's going to take time right now. So you need to be preparing and training. But the key things, in the end, it's a simple thing about social distancing. People understand that. It's a simple thing around hand hygiene. We've been talking about hand hygiene for decades in our communities. So if they can understand how to protect themselves I think this is the best way that we can, try to do no touch, keeping distance, etc. I think that's one of the critical things that we have to make sure that our community healthcare workers know, that have the knowledge to be able to protect themselves. I think, did you have any other question on the community healthcare workers? Is that it?
Well, what about how do you deal with this when you don't?
Oh, the PPE shortage, yes. So again, I think everyone focusing on PPE, PPE is an adjunct to complement our measures. So you don't need a mask if you are 2 meters away from someone to be able to talk to them and deliver services potentially to them. Only if you're coming into contact and providing, looking at the patient or doing an examination. So there are ways to actually limit the use of PPE to try and conserve it. So not everyone, even in a healthcare setting, not everyone will need a mask. So your triage does not require everyone to be wearing masks. You can put up barriers, like perspex barriers, to consult, have one-way flow of traffic. So there are many things you can do without having to use any PPE at all. So I think one of the critical things is that not to have this over-reliance on something as your only protection in this whole situation. And if you see, and we've actually produced some guidance on how to conserve PPE, which we would be happy to share with others. But again, it's a complement of many things: distancing, hand hygiene, plus masks and face shields, by the way. Seen a lot of people wearing masks without actually covering their eyes as healthcare workers. So it's using it appropriately, trying to minimize the usage of it. And I think the final thing is, is some alternate mechanisms. So, if we could all use manufacturing in local settings to produce face shields, for example, that would be great. So these are things that we need to start thinking about now as cases increase. I'll stop there.
Thank you. We're going to try to stop. We're maybe 2 minutes late. So maybe 2 minutes to Mohammed and 2 minutes to Darren.
Yes, I will be very, very quick, Paul. Thank you. I mean, technology, the question about technology, yes, it is essentially required. It is essentially required for different level of services, depending on what type of services you are trying to provide or deliver through the remote delivery model. So the internet definitely is not essential in our model. We definitely will need it if we move ahead with the communicable diseases and some other illnesses for which definitely you have visuals. I mean, and it is impossible to reach to even a for provisional diagnosis. So that is the answer about the technology essential, but we can mold and customize the model to different countries, different with the context. So that is possible. I will be very short in my answers. For the government, it is the collective wisdom of the UNHCR and the government of Jordan that the Ministry of Health will be responding to the COVID situation. So far, this scenario has not been taken into account that what if, for example, there is a dramatic increase in the number of cases. So it has not been taken into account so far. So that is the answer.
Okay. And Darren, over to you. You're on mute. Can Ryan, can you maybe, or can we try to unmute Darren?
Really quick, without even network coverage in most of the camps, a lot of the technological solutions are just not really available to us right now. Our focus is much more on what Michelle was talking about, and that's just how do we improve IPC, how do we increase social distancing in all of our SOPs in our health facilities and in our community surveillance. It's conservation, it's alternative PPE methods, it's engaging people in new and different ways, but it really does rely on a lot of face-to-face work.
Great, thank you. So Michelle, Mohammed, and Darren, thank you very much. Interesting, also and two very, very different scenarios, Jordan and Thailand. So it's been fascinating. Thank you. We, as briefly, next week we will have, our session will be on mental health, and we'll have from the headquarters level, WHO and UNHCR doing some presenting, and then we were likely have, I think it may be Uganda, an NGO in Uganda responding or discussing what's happening in Uganda proper. Please remember to update your Zoom all the time, because last week, as you know, we were hacked, which is one of the reasons why we were limiting the amount of people that could use the chat. Thank you very much, everyone, and have a good rest of the day and evening. Bye-bye. Thank you, Michelle.
Thanks, Paul.
Thanks, Darren.
Thanks, everyone.
Bye-bye.
Thanks.